The information provided on this podcast is for general informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your qualified health provider with any questions you may have. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Reliance on any information provided here is solely at your own risk.
Welcome. This is Birth, Baby. Your hosts are Sierra Morgan and Samantha Kelly. Sierra is a birth doula, hypnobirthing educator, and pediatric sleep consultant.
Samantha is a birth doula, childbirth educator, and lactation counselor. Join us as we guide you through your options for your pregnancy, birth, and postpartum journey. Thank you to our listeners for your continued support. If you enjoy our content, please be sure to like, follow, rate, and review wherever you listen to podcasts. This helps us gain visibility to other people that could benefit from listening in. Hello, everyone. Today we are going to talk in this fertility series that we've been doing about medicated cycles, IVF, IUI, all the things when people are trying to get pregnant. So it's just Sam and I today. Hello, Sam.
Hi. It's been a while.
It's been a while since it's just been the two of us. I know we've had a lot of guests lately. I don't know in the order that they're coming out if it's going to seem that way, but I think so. And it definitely feels like it to us in the order of recording. So this whole series was your, baby, your idea baby. And I'm really excited that we're on this one because we've talked a lot about people's struggles with fertility. And we haven't talked and how to optimize fertility, but we haven't talked about some of the things that people do as much in order to get pregnant or attempt to get pregnant outside of just the old-fashioned way. So assisted reproductive technology, shortened to be ART, so that we don't have to keep repeating that. Can you tell us a little bit about what it is?
Yeah, definitely. So, as we've worked through this whole series, we've talked about acupuncture and diet and cycle tracking and mindfulness for fertility and all of these different things that you can do to optimize, that you can do, as maybe a little bit of a starting place or even an assistance as you're going through some things. But in the long run, there are a lot of people who are going to need help getting pregnant in some form or another. So when we're talking about what that help may look like, that's where ART comes in. So ART refers to medical techniques that are used to help people get pregnant when getting pregnant on their own is difficult or just not possible due to a bunch of different things. These could be people who are experiencing infertility, secondary infertility, same-sex couples, people who are solo parents by choice, or people with certain medical conditions who just aren't able to conceive on their own. So about 12% of people between 15 and 44, according to the stats that I've seen, have used fertility assistance at some point in their reproductive cycle, with about 1 in 42 babies being born as a result of some form of ART, which as our experience as doulas, I would say that's pretty accurate. We would almost even say higher.
Yeah, I was going to say, I feel like our clients, it's higher. And first of all, if you're listening, you're like, y'all, you're just two doulas. Who are you to be teaching us about all of this stuff? You're right. We are just two doulas. Neither of us, I don't think, have gone through any of these things. I'm like, unless Samantha's hiding something from me that I didn't know. But all of those things that you just said, same-sex couples, solo parents by choice, people with certain medical conditions, people facing infertility, all of those, that's been our clients. We have experience with all of these things and surrogacy, so yes, people having infertility issues, but then having somebody else do it for them and they still have to go through IVF or whatever. And I would say probably 30% of our people our clients are these people. So ours is maybe,
easily,
much higher than 1 in 42 babies. And much higher than 12%.
Absolutely. Which, by the way, looking at those numbers, it says 12% of people between 15 and 44. I'm like, what 15-year-old is using?
Okay, so I didn't think about that, and I
don't know what that's about. But those were the stats that were out there.
That's very interesting. Why are we including that?
Exactly.
Not that they're not important, but I highly doubt they're doing
I hope they're not using
IUI or IVF.
Technology. That's a little much, but that's neither here or there. So today we're going to just talk a little bit more about that. So y'all know I love to research things. I love to learn more about things. And as we have gone through our experiences as doulas of supporting people, we've gotten exposed to a lot of these different things. We've had to learn a lot about all of these different things. And then, even through like building our academy and different things like that, we've chosen to learn more about this. So that's kind of where this knowledge base is coming in. Like she said, we're not medical professionals. So we're just going to kind of give an overview, if you will, on what some of the different options are and who might be looking to use some of these options and like what scenarios they might be helpful in.
Yeah.
So we're going to start off by talking about maybe what the like first step in a reproductive support journey might look like. So the first step in that, you're having a hard time getting pregnant, they're trying to figure out why, they might start with something called a medicated cycle. This would be like an ovulation induction cycle where they're trying to induce ovulation so that you can like time your love making, your baby making time to your ovulation so that you have the highest chance of getting pregnant at that time. So you would probably be taking a medication, might be like a Clomid or a letrozole to help your ovaries to release eggs. A lot of times this is combined with like timed intercourse, like I said, or even an IUI to increase your chance of conceiving. We'll talk more about IUI in a minute here. So usually this is pretty monitored by your doctor with like blood work and ultrasounds to track your response. They just kind of want to see, like, we want to give this medication to make sure that you are ovulating, releasing that egg, and then we're timing intercourse to go through with it. So this might be for people who have really irregular cycles, especially women that are experiencing like PCOS, polycystic ovarian syndrome, or having just unexplained infertility, especially people who have like secondary infertility where they have previously gotten pregnant on their own. And then now for whatever reason, they're just not able to conceive on their own this time. So they use a little bit of assistance. I've heard of like, we've had clients who after they're done breastfeeding, their ovulation is just like not coming back in the same way, and they're ready to conceive and they can't get their cycle to come back. And so they might do something like this to like induce that ovulation.
I also knew somebody that wanted twins so badly. And so they asked their doctor to use this to try to drop multiple eggs so that they would be able to have a higher likelihood of having twins. And this is something we hadn't talked about before planning this episode, but we even have a client who the husband took Clomid because it actually is used off-label for helping treat male infertility, and it blocks estrogen. So it leads to higher testosterone and sperm production for men that have a low sperm count or hormonal imbalances. So we actually had one, for her first 2 babies, he was on Clomid, which when she told me that, I was like, and when she first told us that, I was like, I think she's wrong. Like, I don't think that's no, but then I looked it up and that was a real thing. And then she got pregnant for her 3rd baby. And she's like, but he wasn't on Clomid. Like, we didn't think we could get pregnant without him being on it. So yeah, this is even used for men off label.
Wow. Yeah, I had not heard that. I know which client you're talking about, but I didn't realize that was the medication they were using. That's really cool. So yeah, I mean, there's a lot of people who have used this with success. There is a chance of releasing more than one egg, much higher chance with like Clomid or letrozole. So this is something that a lot of people are sometimes a little bit hesitant about. I have a really close friend who had been trying for a long time with secondary infertility, and she was doing everything she could to avoid doing this because she was really worried that she would release multiple eggs and have twins, and that was just not something that she wanted. So that was a little bit crazy.
It would make me nerve-wracked. I would be like, absolutely not. I don't think I can do it.
Yeah.
Just the chances. No chances, please.
Absolutely.
Okay, so then we do have intrauterine insemination. This is a little step further from Clomid. This is a procedure where the sperm is placed directly into your uterus during ovulation. So it's kind of bypassing the application naturally in going, hey, let's go straight to the source. Let's put it right on in there in case the sperm was having a hard time getting in there. That's the goal, is getting it closer to the egg to improve the chances of fertilization. And it's usually paired with, like we said, the fertility medication of something like Clomid, and encourages multiple eggs to like increase the chances that the sperm is going to get one of them. So couples with mild male factor infertility, or same-sex couples using donor sperm, or those trying to conceive with help but not ready for IVF. In some states, it is possible to do this without the assistance of a doctor and using a midwife out of hospital. So that's really cool. This could be something that you can do, not having to go to all of the fertility clinics and all of the hardcore stuff. Maybe somebody isn't really ready for that. And some people just have a little bit of white coat syndrome anyway. And they're like, I don't want to go to a doctor for any of this. So they want to try something outside of that.
I'm thinking of that. There's that movie with Jennifer Aniston, and she does this method like with her friend. I'm totally spacing on the name right now, but they do it like at home with the like turkey baster method. And which I don't know a whole lot about that, but I know it's something that people do.
I know people that have done this.
Oh yeah, I absolutely know people who have done this, and it's just is what it is. Like that's some people, especially like same-sex couples who are using like a known donor or something like that. That would be a much cheaper method. I don't think it's actually a straight up turkey baster, but maybe it is. I don't really know.
I mean, I think that will work.
I think so, probably, right?
That's what I'm going to have like the podcast art for this one. I'm just going to put a turkey baster.
We're very professional, you all, as you can see.
Yeah, we've been here for a couple of years now, guys. You know.
Absolutely. So one thing about these first two methods, the medicated cycle and the IUI, is that for all like intents and purposes, once you are pregnant, you're basically like naturally pregnant. This is a baby that took and grew on its own, and there's not really any added risk at that point. And then when we start getting into IVF, there's some added risk. There's a little bit of a high, some doctors would consider that a higher risk pregnancy. So IUI and medicated cycles, you would be considered just a regular, naturally conceived pregnancy once you were established pregnant. And then when we move into IVF, it is a little bit different. So we'll talk a little bit about that as we get into the IVF, because that is something that I think a lot of people don't necessarily realize when we talk about IVF, is that there are some risks that go with that, just some things that we pay a little bit more attention to when it comes to an IVF pregnancy. And we'll talk a little bit about that as we dive in.
Oh, that's our next topic. So let's dive in. In vitro fertilization. This one is a little more involved, my friends. Mm-hmm. So tell us what it is.
Yeah. So in vitro fertilization. So when somebody makes a baby, when a baby is made, there's the egg and there's the sperm, and they have to meet with the IUI and the medicated cycles and natural conception. That's happening all in the uterus, right? With IVF, that's happening outside of the uterus. So eggs are going to be retrieved from the ovaries and then fertilized with the sperm in a lab after some testing and all of that to see which eggs are mature enough for fertilization. Because not all of your eggs that they retrieve from that procedure, that egg retrieval process, is going to be ready to be fertilized. So fertilized eggs are then, once they've gone through that testing, the fertilized eggs are then monitored really closely, and they're given a grade based on which are more likely to implant and lead to a healthy pregnancy. So there's like a AA, AB, I think it goes all the way down to like a G or something like that. So there's a lot of different grading based on that. And one thing to know about that is that the grading doesn't necessarily, it's not really the end all be all. There are people who have had plenty of people who have had AA embryos implanted and they don't take. And then there are people who have implanted much lower grade embryos, and those are the ones that take, and they're just fine. So it's kind of like a best guess of the situation.
I'm going to say something that's going to sound ignorant, and that's okay because we already said that we're not medical. Is this also where the mosaic qualification comes in? I know that's like really deep into it, but is that the same as a grade?
That is the next part of this, actually. So that would be genetic testing. So they go,
because I know some people have like great genetic ones, and those don't even sometimes work. And then they're like, "Oh, we're down to the mosaic ones, which is like not as optimal." And even that can work. So
yeah, exactly. So there is the grading, which is going to happen all the time with IVF. And then there is genetic testing that is an option that not everyone chooses to do before implantation. And that's going to rule out any genetic or chromosomal defects. So not all families are going to choose this option. So like the mosaic thing is going to be, there's a higher chance that this embryo could develop Down syndrome or something like that, than otherwise. That doesn't mean that they always will. It just means that there is a chance of it. But not all families choose to do. Yeah, it's wild. It's absolutely wild.
And some people, you're already spending so much money on doing everything before this that they're like, I can't possibly do the genetic testing too. But every time you implant one of these, you have a chance, like that costs money, every single implantation. So if you do the genetic testing first, you know kind of which order to do it in to make it so maybe you're not spending as much down the road on as many, implantate or IVFs. So gosh, it's so hard.
Yeah. And I think like it's kind of getting into the weeds of it here. There's a lot of like ethical conversations that can come into this process.
I was not doing that.
No, but I think one thing to think about with the genetic testing too is that it's not necessarily so that you won't have a baby that has those things. It's that most miscarriages, especially early miscarriages, are because of chromosomal defects in the embryo. So when you're implanting embryos, you want them to have their best chance of sticking. And so we don't want to necessarily implant ones that are going to already have some of those defects or chromosomal defects.
And we can choose boys and girls here.
That too. Yeah, absolutely.
You could choose birth order here,
Mm-hmm. Yeah. If you always wanted the boy first, maybe you want a family based on your own. There's, again, getting into the weeds of it here. A lot of people are going to have a lot of opinions, but it is a really interesting topic. I'm thinking about this right now because I'm rewatching Private Practice, which is like a total trashy telenovela sort of drama medical show. And they talk a lot about this because it's like, she's a neonatologist, surgeon person or whatever. And so they're talking about like genetic testing and all of these different things and like what's ethical and what's non-ethical.
Gosh, that's so hard. I'm so glad I don't have to make any of those decisions.
Oh, so totally crazy. So I'm thinking about this in the frame of that TV show right now. So if anyone else is rewatching Private Practice, maybe you know which episodes I'm talking about, but it is really interesting. So once families have gone through that grading process, maybe they've chosen to do the genetic testing or not chosen to do the genetic testing, they will, the embryos, the fertilized eggs are going to go through a process where they're going to kind of sit and fertilize and then grow into the embryo. And then one or more of the embryos are then placed in the uterus, hoping for implantation. Some families will choose to implant one at a time. Some families will choose to implant two at a time. There was a time when all of this was fairly new, where they would just kind of free for all it, and that's how we have like the Octo Moms. There's a documentary coming out talking exactly about that right now, and I'm so excited to watch it because it's so
that's kind of cool timing.
Yeah. But all of that is absolutely possible. And it's also possible that with IVF, those eggs can still split and there could be twins or something like that too.
Yeah, true.
So lots of different things there. IVF is a really involved process. So it's going to involve hormone injections. So like the Clomid and different things like that, you're also going to be taking that. It's going to involve a lot of monitoring. You're going to your fertility specialist a lot. It's going to have that egg retrieval. It's going to have the embryo transfer. And then after you've had your embryo transfer, they're going to bring you back in for blood tests and checkups for, at least the first, I think it's 6 to 8 weeks, depending on who your fertility specialist is, of monitoring before you are released to your regular OB once you have an established pregnancy. So who is IVF for? This might be for people who have blocked tubes. Their eggs are just not able to fall into the uterus. It could be people who have endometriosis or age-related infertility or recurrent pregnancy loss, and they want to make sure that they do have an embryo that is most likely to make it. Or this could be for couples who have just tried everything else and they have not had a lot of success. So there's
some people are getting
things.
older and they're like, yeah, I could try, Clomid first, or I could try IUI first. But actually, I'm just going to go straight to IVF because I don't have the time in their own head. They don't have the time to waste doing all of those things if they might not work. And they're like, let's pull out the big guns first. And they choose to do this instead. So you don't have to do these in any certain order. Some people change up the order. But yeah.
Yeah. And this can also be for same-sex couples who maybe want to decide who's going to be carrying whose baby, or for men, if they're using a surrogate, they're going to be using IVF for that process. So there's a lot of different options that can be used with IVF, and it can be a whole thing. So I talked a little bit about how IVF pregnancies can be a little bit different than a naturally conceived pregnancy. And that is because the baby is grown in a different way. The embryo is grown in a different way. And so there's some things that they've noticed with IVF pregnancies as we've done more research, and we've had a lot more of this over the last 10 to 20 years. And that is that people who have used IVF to conceive are more likely to have placenta issues. A lot of times, what we see is that at a certain point, the placenta just kind of decides it's done a little bit sooner than it would in a naturally conceived pregnancy. So a lot of providers have a kind of hard out at 39 or 40 or 41 weeks rather than going up to 42. And there is definitely some iffiness with this.
Yeah, this is one of the things that because there are so many comorbidities with IVF or with infertility, sometimes it's unexplained infertility. We don't know why. Sometimes we do know that it was a blocked tube. Sometimes they have some other medical conditions that are making it hard to conceive, or blood sugar issues or whatever. And so recently, I think you sent me something from Evidence-Based Birth that was talking about induction for certain reasons, and IVF was being one of them. And it was I had somebody in one of my classes talking about how, is it chicken or the egg? Is the placenta breaking down sooner because it was built via IVF, or do we have IVF because we already had a situation that would have caused a placenta to break down sooner? So again, not enough research here.
Definitely not. And I don't know how long it'll take before we have those answers.
Ever. I feel like forever.
We've also seen things like people with IVF are more likely to develop preeclampsia or even gestational diabetes, which again, chicken or egg, we don't really know, but there is definitely a correlation. What the causation is, who knows? But there's definitely a correlation there. So those are things that we pay attention to. So most people who have an IVF pregnancy are likely going to have a little bit more monitoring than a naturally conceived pregnancy. Some providers recommend, what is it called? A fetal echo early on, which is something I hadn't heard about until recently.
Same. Some of our clients tell us stuff, some don't, and they don't have to tell us everything. But recently we did have somebody talk about that as if it was just so normal. And I was like, no one shared with us that they got a fetal echo due to, because we're like, oh, why? Why did you have to get that? Because it's IVF. Okay, I didn't know.
Right. Of course, we knew that. So there's things like that. And then towards the end, there's likely going to be a couple more growth scans. There might be more biophysical profiles, different things like that. And then again, some providers are going to have really strong opinions about having a hard out at, I don't want you to go past this state, which of course, when we're talking about any of these things, everyone gets to decide what is best for you and your body. You can say, yeah, I'm okay with that, or no, you know what, I'm not. We have had people with IVF pregnancies who have had the most beautiful home births with very little intervention and not really any different in the way of monitoring. And then we have had people who have had 39-week inductions and all of these different things because it was an IVF pregnancy and have been very heavily monitored. So there's so many different feelings about this, but overall, you can expect that it'll at least be a conversation at some point in time. And there's also an aspect too of IVF is hella expensive, especially in the United States where we don't have a lot of coverage for that with insurance. And so when you've spent that much money trying to get pregnant, you also really want to make sure that everything is okay and we get to the end with the least amount of drama as possible.
And not just money, but the emotion that you've put into it. You've tried so hard to have a baby, and you're much more likely to be coerced into something that maybe you wouldn't have wanted to do before because you're scared. And so having a provider that's congruent with how you think is really important here too, because you're at a much more vulnerable position, I would say, with an IVF pregnancy than you are with a spontaneously conceived pregnancy, or maybe not IVF, in general, infertility and then a pregnancy, or loss then a pregnancy, versus spontaneous pregnancy with no past history of any of that, because the feelings are so much more complicated. And you may have been like, I want all of the unmedicated everything, no intervention. And now you're like, sign me up for every freaking intervention and induce me at 37 weeks so that I can see them breathe on the outside. And that's okay. All of those options are okay.
100%. Yeah. A couple of the other things to know about IVF is that this is something that can be used with a donor egg, which is where maybe if you aren't able to, or maybe your eggs, you don't have enough eggs, or your eggs are just not the quality that they want to see, you can use donor egg just like you would have donor sperm. And so they can use IVF and then implant that donor egg with either your partner's sperm or someone else's sperm, and implant that. Or same thing, they can use donor sperm to fertilize your egg. So there's a lot of different things that can go there. With same-sex couples, sometimes it's that one mom is implanting the other mom's egg into her uterus so that they can carry each other's babies, and they get some of that DNA crossing, even though, biologically the child is the other parent's. It's all really, really interesting. So I don't know. It's cool stuff. It's crazy.
Yeah, it's cool. Very nuanced. And we just, there's so much that goes into it, but we wanted to give you guys a brief overview at least so that you can kind of understand the options. And maybe this isn't something you've ever even considered for yourself, but somebody going through it. And this is, something that you wanted to educate yourself in, and good for you. So it can be very physically and emotionally demanding. It's totally okay to have complicated feelings. And if you're a family member that's supporting, or a friend that's supporting somebody through this, remember that and give grace. Every family building journey matters. Your story is valid, and everyone deserves care that honors that. And having, again, that provider that is supportive is so, so important. And there's no right or wrong way to do this. We've given a lot of examples here, and you get to choose the path that's right for you, and do it in whatever order you feel is right for your family.
100%. Every story is valid. And as we've talked through all of this fertility stuff in the last few episodes, a lot of people are using those things along with fertility treatments like this to optimize the chance their IVF or IUI or medicated cycles go well, or just to, our episode with Tracy talking about mindfulness, that is hugely beneficial in this ART process. So
if you haven't listened to those, go back and listen to those for sure. That will be really helpful. If this is something that's applying to you, those will be really, really helpful. Yeah. So thank you guys so much for being with us on this fertility journey that we've been doing. And we will talk to you next time.
Thank you for joining us on Birth, Baby. Thanks again to Longing for Orpheus for our music. You can look him up on Spotify. Remember to leave a review, share, and follow wherever you get your podcasts. See you next week.